Thank you. Good afternoon, everyone, and thank you so much to the organizers for the opportunity to be here. Today, I'll be presenting some of the findings of a case study that was conducted in rural Mexico, and this aimed to draw some lessons about the implementation of mental health programs in rural settings. So, briefly about the outline, I'll be presenting a bit of the background, so why focusing in integration of primary healthcare. Also why I decided to use an implementation science approach to look at this. And I'll be explaining a bit about the study and some of our findings. So first of all, what is the importance of talking about integration to primary healthcare? So according to GVD analysis, depression and anxiety are among the leading causes of years lived with disability globally. Some estimates before had established that by 2030, depression would cause more deaths than any other condition. Despite this, we see that some estimations have calculated that between 79 and 93% of people worldwide do not access treatment for depression, and the proportion is even higher for people who suffer from anxiety. So, for this reason, it was a global call that it was important to scale up or to increase access to treatments for mental health care, and this was and the WHO endorsed as a key strategy to increase access to care, to integrate mental health services in primary health care. And so the WHO also did, they developed the MHGAP action program, some key clinical guidelines that are still quite important for, widely used for the training of non-specialist health workers, and also some training manuals. So, why using an implementation science approach? So a few key challenges to what are to the barrier, some of the barriers to integrate mental health services in primary healthcare in low and middle income countries have been identified. So one of them is how primary healthcare providers are already overburdened. Also, it has been pointed out that there is a lack of supervision or support from specialists to primary healthcare providers, and also even when people can diagnose and maybe allocate a treat or prescribe a treatment, many times the medications are not available. So we know that difficulties implementing a new practice go beyond resource shortages. We know that there is a lot about management and how resources are administered, and that there are also multiple elements that are involved in an implementation approach allows us to acknowledge all these many elements that are involved in integration in primary health care. So we know that for integration, we many times require complex interventions because we need interventions for different, so especially in mental health, and probably for most of diseases, we need interventions for different levels of severity that are delivered by different people. In terms of multiple stakeholders, we have the providers, but we also have families and service users. And we also know that all these programs are being integrated in very challenging health systems, very complex health systems in themselves, and in very challenging contexts. And so this was why I decided to approach these research questions of what factors influence the uptake and sustainability of mental health programs in primary health care. And so specifically about this study. So our aim was to further understand implementation of programs for common mental disorders in primary healthcare platforms. And I focused in common mental disorders because, as I mentioned, these are the ones that cause the highest burden, and also there is a lot of evidence of the comorbidity between depression and anxiety and physical conditions, certain physical conditions. And we identified a program that was being successfully implemented in a very challenging context, in a rural context in Mexico. And so we wanted to examine how implementation looked like and what were the factors enabling it and some of the remaining challenges. And so a very key aspect of implementation is context. So I will start with where this program is being implemented. So it is being implemented in Chiapas, which is a southern state in Mexico. It has around 5 million inhabitants. It is a particularly challenging context because half the population live in rural communities and 3/4 live in poverty. It's very mountainous, and the road and telecommunications infrastructure is very poor. In this state, depression and anxiety are among the 10 main causes of disability. But despite this, again, mental health treatments are only available at the psychiatric hospital and ambulatory mental health unit that are in the capital city of the state. In theory, in the state, mental health services are available at primary health clinics, but from observations in the field, I can tell you that this is not actually happening. So in terms of the specific program that I will present to you, so this program is led by a non-governmental organization that is called Compañeros en Salud. It's a sister organization of Partners in Health, and they deliver services through a partnership with the Ministry of Health in 10 communities that are located in the Sierra of the state. It's a very, very mountainous region. And so these 10 clinics that they are running are in 10 different communities, which are around 6 to 8 hours from the capital city. And it involves like multiple transportation. So you take a van, and then you take a bus, and then you take another bus, and then you finally make it to the capital city. So it's very difficult to reach these specialized mental health services. To give you a sense of the size of the program, in 2016, they gave around 28,000 medical appointments, but this was for all conditions. And patients were from 142 different communities. The mental health services that are available, they are delivered by medical doctors in the clinics and community health workers in the community. And services available are pharmacological treatment, talking-based interventions, both of them at the clinic, and there's some psychoeducation groups and home visits that are delivered at the community. And in order to implement this program, the organization uses 7 implementation strategies. So, as I mentioned, they have the home visits. They support the medication supply. So they are the ones buying the medications, and they are providing them to the patients for free. They have a mental health information system with which they monitor the progress of the patients. There's high-intensity training and supervision, and also group problem solving that happens with the medical doctors. So they are heavily supported, and they also ensure that there are materials for clinical decision making available at all the clinics. And so, in terms of these studies, so I used a mixed methods case study methodology, and so to assess the implementation, because the first step was establishing what was actually being implemented. So how did these services actually look like? And so to do this, we extracted quantitative data from the electronic records of patients who attended a consultation during the study time, and only for patients who were above 18 years old, and also that were diagnosed with a mood disorder or anxiety disorder or both. We generated some process indicators to establish what was being implemented, and so we extracted all clinical notes of these patients, and we coded them using a pre-established coding system. And essentially what we wanted to see was to what extent clinical guidelines were being followed at diagnosis, treatment allocation, and in follow-up consultations. And then we used qualitative data, including observations at the clinics, in the interviews, some focus groups, to try and understand, again, what were the factors enabling or challenging the implementation of the program. And to guide the analysis, we use the consolidated framework for implementation research. And I will talk a bit about it in a bit. So in terms of the results, so first of all, who were the patients benefited by this program? So who were the patients? During 2017, we had 486 patients that visited the clinic for a mental health consultation. And the majority, so this is a it is a relatively small program. And 84% of them were female. The majority were relatively young, so between 18 to 39 years old. The majority received a diagnosis of depression and were experiencing severe symptoms when they came to the clinic. In terms of to what extent the guidelines were followed. So 63% of patients were diagnosed according to guidelines, and this means that medical doctors used a screening tool to evaluate their status, but also did a further assessment. So they asked them about their symptoms or relevant life events. And this is really key, because what we want to see is that the medical doctors are not just sort of like trying to categorize a patient in a box and say like, okay, this score is telling me that this patient is feeling like this, and therefore I'm going to give a medication or whatever. So it's sort of like understanding or reflecting that they see that mental health is a bit more than just these very like prescribed set of questions that screening tools often give. And then, but when we see about and it's sort of good to say that 63% were following the guidelines. So we consider that sort of like good outcome. But then we see that for the treatment allocation, only 28% of patients were received the treatment according to guidelines. And this means that this was mostly because the majority of them, and it's 41%, did not receive any psychoeducation or any talking-based interventions. So the majority of patients were being prescribed medication according to the guidelines, but they were only being given medication, and this is antidepressants mostly. And so in this graph, I show you what happened over time. So over the year, how follow-up consultations looked like, and we looked at three different elements in terms of the clinical assessment. So how many use the tool, or in what proportion of consultations a medical doctor did these things. So in 76% of occasions, the medical doctors use a screening tool. In 50% of occasions, they did a further clinical interrogation, and then in 40%, they asked about relevant life events, which is something important for mental health clinical assessment. In terms of the treatment allocation, we see that patients mostly received pharmacological treatment, and again, in a very small proportion, medical doctors also delivered a talking-based treatment. And here I show you what happened with attendance. So we have the net number of patients that attended, but what we see is that there is not much variation over the year. There is a bit of a peak here, and we always, something I forgot to mention is like we always see proportions going down at these months, because I forgot to mention medical doctors change on a yearly basis. And so at the time when medical doctors change, we always see a drop in to what extent they follow the guidelines. And so in terms of attendance, or those like how much treatment patients received, we see that 50% of patients only attended 1 or 2 consultations, and only about a third attended more than 60%, which is what we consider ideal. And so looking at why, starting to explain a bit like why we got these results and how medical doctors were able to implement this program or implement these services. So I don't know if you're familiar with the CFIR, but this framework is a bit popular in implementation research. It is a meta framework that was created through a systematic review, and it reflects empirical findings about factors that are relevant for implementation, but also it was also theory driven. Its creation was theory driven, and so it groups more than 20 constructs and that fall in 5 domains, which are over here. And again, this is all factors that influence implementation. So we have the characteristics of the intervention, individuals, process, and something that the authors call outer and inner setting, which has to do with the inner setting mostly refers to whatever falls under the organization or the people who are implementing, and the outer setting is usually like characteristics that are not under the control or of the implementers. But it's a difficult line to draw because every program and implementation of every program usually changes. Okay, so in terms of the results, so we saw that the first facilitating factor is the engagement that all people who work in the clinics and the organization have with the mission of the organization. So what we see is that there is a very strong commitment to provide good quality care for all people. And this is something that is strongly believed by all members of the organization. And we have, I put some quotes over here. So, sorry, let me just get, oops. So this quote shows us, let me see here, that this is something that brings personal satisfaction to the providers, but also that they have a sense that everyone in the organization is collaborating and being in a supportive environment and with a purpose. So this medical doctor here says, there are days in which you're tired, but seeing that a patient is improving or that she is able to do more things in her life gives you the energy you need. And knowing that it is not only you, but all the work that everyone is doing to improve the model and the way we do things and the quality of the consultation. So yeah, quality is something clearly very important. And that is in terms of implementation climate. So again, like this, it's almost a spiritual factor, that like a spiritual feeling all around the organization. And then in terms of readiness for implementation, so readiness for implementation refers to the extent to which an organization is ready to implement or uptake a new intervention. And there, the constructs that are part of readiness for implementation are the availability of resources, the availability of leadership, and access to knowledge and information. And we see that this is a very key facilitating factor. And here are some quotes. So what we see is that the availability of high-intensity training, supervision, and medications are all key, and they all sort of like provide the ideal conditions for medical doctors to actually be able to do this work. And I think this doctor illustrates it very nicely. So she says, in certain cases, patients need medication, and if you don't have any to give them, it's tricky because you know you cannot give them a prescription and ask them to buy it in the pharmacy. There are no pharmacies in these communities. The closest pharmacy is probably like 2-3 hours away. And then she says, or you can have the best medication, but if you're not trained to use it, then it's useless. Which also talks about the importance of training. And then another facilitating factor, strong facilitating factor, was the process. So through observations, what I was able to see is that the introduction of these monitoring processes, different monitoring processes, including monitoring the patient progression, but also monitoring things like training or how supervision is delivered. These sort of creates an environment of constant improvement. So there is constant feedback being given by the coordinators of the program, and there is a sense in the organization that this feedback is being taken into account, and changes are being made constantly. Changes are being made into the program, and so that allows for improvement, but also makes everyone in the organization sort of feel that if they have concerns or if there are any issues, that these are going to be addressed. And well, finally, in terms of some of the barriers that we found, so I'll start with the inner setting. So again, this also came as a strong theme in the barriers analysis, and so there are some things that have been previously identified by related research, like, for example, the overburdening of providers. These clinics run, so so one of the things was the insufficient time to address all service delivery and monitoring needs of the different health programs. So in these clinics, providers are delivering services for mental health, but also for maternal health, also nutrition programs, and this is quite common in primary health care. There are tons of programs that are being delivered at once, and most of the times primary health providers are, I don't know, they receive like a 1-day training, 2-day training, and then they are expected to do all of these different activities. And then there is also, like, there is not only the actual delivering of the services, but there is also all the paperwork that comes with them, right? So, like, making sure they are filling all this information about these indicators. And in Mexico now is trying to implement this new electronic system, but until now, all of the indicators are reported through paper-based forms. So nothing is online. And this health provider says, he illustrates it very nicely. So he says, it's difficult to provide quality in all areas. Each person provides quality and focuses on what they care the most about, or on what they feel they have the most expertise in, or whatever area they feel they can help the most. But there are too many tasks. And I think this is quite key, because it is not only, for a lot of time in the field, it was all about increasing access to care, but with implementation has also allowed us to ask the question of, like, okay, but how does that care look like? Like, it's not only about increasing access to care, but increases access to good quality care. And there are certain there are certain factors that we need to take into account to actually make that happen. And then another important barriers where I think I like to focus on the outer setting and the needs of the patients. Sorry, I will go back. Another important thing that I forgot to mention is, so as I mentioned before, medical doctors perceive as important to have access to training, but they feel that this training has its limitations, that there is only a certain amount of things that they will be able to achieve with the training that they provide. And so in terms of the token-based interventions, there was this constant reporting of, like, we don't have enough support to actually be able to do this. And we never really received training to do any of these things until until they came to deliver this program. And then finally about the outer setting. So another very strong thing was the patient's needs and expectations. So the one important thing is that a lot of the patients that are diagnosed with depression or anxiety, they come in with physical symptoms, so headaches, backaches, and that sort of thing. But then medical doctors realize that a lot of the origins of their distress are social. And again, this doctor says something very key about it. So she says how it is difficult to treat mental health patients because many times, she says the difficulty is not knowing what to say because the majority of mental health patients do not have a fixable problem. The situations that lead to their mental health problems, how to do with the violence that they live or life situations over which the medical doctor has no control. And this has important implications with also the support from a specialist or other services that there are available. So they feel that a lot of the patients' need, they just can't address, and that there are no social services or specialist services to be able to really provide a good quality care for these patients. And finally, and in that sense, the lack of accessible and good quality secondary and tertiary services to refer patients was another very common reported barrier. Just to finish, or to highlight some of the conclusions of all of this. So we see that primary health doctors they followed guidelines for clinical assessment and follow-up. We see that treatment guidelines are still not followed in the majority of cases. We also see that the majority of patients did not attend more than 2 consultations, and that is very important because I think it speaks about to what extent this program is actually catering to the patient needs. And and it seems that a lot of them are not being addressed because patients are not returning. And we see that the availability of training and supervision within a supportive learning environment, they allow providers to deliver certain services for mental health. But on the other hand, competing priorities within the clinic, insufficient resources, these two things hinder the capacity of providers to deliver high quality care at all times. And I think another very important thing is how most health providers, and I think this is true for many settings, like they care about this. They really want to provide good quality care, but it is difficult. And then finally, the sources of distress of patients are difficult to address in a clinic setting. And I think in integration of programs in primary health care, secondary and tertiary services have often been overlooked in the planning stages. And I think, and this is something that needs to change if we actually want to provide care that benefits all patients. Now, primary healthcare providers can't do everything and can't deal with all illnesses. And then finally, some more than recommendations, some implications. So case studies are a really useful tool to understand implementation of programs to support similar efforts. As it was mentioned before, in implementation, it is difficult to generalize, but there are definitely common elements that can be identified. And also, case studies are really useful to see what challenges have been faced previously by implementers, and then see if this is if the ways in which this have been overcome can be useful to apply in other settings. And then, yes, about implementation of mental health programs in primary health care. Strengthening the primary healthcare system is necessary. One thing that has been suggested is to advocate for horizontal funding instead of vertical funding. So strengthen the system versus just allocating funding for individual diseases. And lastly, well, the health system, the primary health system needs to be supported by good quality secondary and tertiary services. And oh yeah, this is very important as well. Implementation needs to be an iterative process, and we need to take multiple stakeholders into account, including the service users. Thank you.
Thank you.